So without further ado, I'd like to present Dr. Matter from Spectrum Health. He is our physician champion for Spectrum Health. He is an expert in the field of radiation and how it relates to the cath lab, and is very well versed on the subject. So welcome, Dr. Matter, and thank you very much for addressing the BMC2 coordinators.
Yeah, thanks, Kathleen. Can you guys hear me okay?
Mm-hmm. Yes.
Great. So these are my disclosures. I do receive research support and give talks, as well as serve on the advisory board for Corindus, which is a vascular robotics company, which is recently purchased by Siemens Healthineers. And so, as you guys know, Siemens does produce fluoroscopy systems, and so I included this as a disclosure. So I think, I really wanted to give the coordinators on the call today just an understanding of why there has been this interest in collecting, this data on radiation doses, and how that is important, I think, both for our patients as well as our cath lab teams that are working in the cath lab every day. And so I think just wanted to start with the effects of radiation and understanding that there are both what are called stochastic and deterministic effects. I think the names of these are less important, but I think understanding the concept is quite important. Deterministic effects are dose-dependent direct effects of radiation on health. And so these deterministic effects only occur once a certain threshold dose is achieved. And the kind of classic deterministic effect of radiation is a radiation burn. And so a burn on the skin won't happen until a certain dose threshold is met or exceeded. And then there are stochastic effects of radiation for which there is no dose threshold. The probability of developing a stochastic effect from radiation is proportional to the dose, and the severity of the effect is independent of the dose. And kind of the classic stochastic effect that is a risk from radiation exposure, of course, is cancer, where there's no amount of threshold below which radiation, that your risk for cancer goes away with radiation exposure. However, the probability of developing cancer from radiation exposure goes up as the dose goes up. So again, probability of developing this is proportional to the dose. And then, of course, the severity of cancer is independent of the dose that you get. And so, again, just an important, I think, for everybody to understand the difference between deterministic and stochastic effects of radiation exposure. And so, for patients who are undergoing, either diagnostic catheterization or PCI in the cath lab, there are several different metrics that we use to determine what the patient's radiation dose is. Fluoroscopy time is one measure of radiation. It's basically the amount of time that fluoroscopy is used. It's not a good measure, however, of the total patient radiation dose, because fluoroscopy time has about 1/10 of the dose of cine angiography, and cine angiography are the images that we typically store for evaluating at a later time. And so fluoroscopy time is a poor estimate of the total dose because it doesn't account for that time that we're using cine angiography. Air kerma, which is you're going to hear me talk about a lot today, is the X-ray energy delivered to air at the interventional reference point. And this is really the best way to assess the risk of a deterministic effect, basically a skin burn in a patient, and it's measured in the units of gray. And so we'll talk a lot more about air kerma as the talk goes on. Dose area product is another measure of radiation exposure to a patient. It's the product of the air kerma in the X-ray field area. And this is most commonly used to assess the risk of stochastic effects from radiation, so basically cancer. And then there's the peak skin dose, and this is the maximum dose received by any local area of the patient's skin. And so, the air kerma is kind of a rough way to assess what a patient's risk of skin injury is, but to really accurately determine what the risk of skin injury is, you have to have a physicist calculate the peak skin dose. And again, peak skin dose is not directly measured, but rather it's calculated from the air kerma and other variables. And so these are the radiation doses at which patients can develop skin tissue reactions of basically skin burns. And so you can see here that if the skin dose in gray is 2 or less, that there's really no risk of developing a skin burn or skin injury from the procedure. However, once the dose goes up above, once the dose goes up above 5, that there is a risk of developing skin injuries. And so that's why, we look at, use this threshold of an air kerma of greater than 5, because that's the level at which you can start to see risk of skin injuries from being in the cath lab and undergoing the procedure. But importantly, just to again clarify, the air kerma is something that the fluoroscopy system spits out at the end. So it's an easy way to know whether we've approached this threshold. However, these on the table are actual skin doses that have been calculated, not air kermas. But again, the air kerma is a way to kind of have a rough estimate of this. And so on the left, you see a couple of examples of skin burns that patients unfortunately developed after catheterization. These burns are present usually on the patient's back, and you can see the skin doses associated with each of these burns. The one on the top, a dose of 11, the one on the bottom, a dose of 18. And so this table here on the right shows suggested values in the cath lab that we should be notifying our team, our physicians in our team, when those levels have been reached. And air kerma, again, is the most common thing that is used in the cath lab. And so the authors of this paper had suggested that the first notification go out at 3 gray to the team, and then every gray above that, that the team gets notified that they've gone up another gray with their dose. And then this SRDL, which stands for substantial radiation dose limit. Again, this is the dose that might produce a clinically relevant adverse event in an average patient. So this is the dose at which you start to worry about the possibility of skin injury, again, an air kerma of 5. And so in our cath labs and during our procedures, once we hit an air kerma of 5, we really should be thinking about stopping the procedure if it's feasible in order to avoid the risk of having a skin burn. So the authors of this paper, so Charlie Chambers in 2011 published these recommendations in conjunction with Sky, what to do if the air kerma is greater than 5. And so once you hit that threshold of 5, you really should be notifying the patient that they had a high radiation dose. The patient should be instructed to check for skin damage, basically redness on their back within the first 30 days. I think that patient should also undergo a physical exam by a physician to look for evidence of any skin burns or redness on the back. And the patient should be contacted at 30 days, again, to inquire about whether they've had any changes to their skin. If the air kerma dose for a procedure is above 10, that is when a qualified radiation physicist, which all of your cath labs should have, a qualified physicist should calculate the peak skin dose to really hone in on what the true risk of skin injury is. And again, if the air kerma is greater than 10, an office visit between 2 and 4 weeks is recommended so that you can examine the patient's back. And then if you hit an air kerma of greater than or equal to 15, you really should be contacting your hospital risk management and considering notifying regulatory agencies. This paper in 2011 had suggested that a peak skin dose of greater than 15 is actually considered a sentinel event by the Joint Commission. And I think that really has to do with the fact that if a patient gets a bad radiation burn, they really can be challenging to manage because they don't heal very well. And so these can create, definitely long-term problems for patients. And so if you hit a dose of 15, you should be contacting your hospital risk management group. So we studied this with the data that all of the coordinators collected. We recently studied this in the BMC registry, and the study that we performed was really to evaluate the frequency and institutional variability of patients having radiation doses with an air kerma of greater than or equal to 5 gray during PCI procedures in the state of Michigan. And we wanted to determine the patient characteristics and procedural factors that were associated with these high doses. And then we also wanted to determine whether the hospital at which a PCI is performed is independently associated with the odds of having a procedural air kerma of greater than 5 gray. And so, you can imagine in an ideal world that if any given patient undergoes a PCI, and it's the exact same PCI that's going to be performed, that radiation dose really should be the same regardless of which hospital it's performed at. And we wanted to determine whether the hospital at which the PCI is performed is impacting what the likelihood of having a high radiation dose actually is. And so the study population that we looked at was between July 1st, 2016 to March 31st, 2018. In that time frame, there were over 49,000 PCI discharges in the state of Michigan. This was at the 33 hospitals with on-site cardiac surgery. There were 5 hospitals in that group that did not report any air Kerma values during that time frame, so these hospitals were excluded. So the ultimate study population that we had for this evaluation was 28 hospitals and over 36,000 PCI procedures in which the air Kerma value was reported. And then down at the bottom there, you can see at the 28 hospitals reporting air Kerma values, the rate of missing air Kerma values in any procedure ranged from anywhere from 3 to 80%, depending on the institution. And the average number of missing air Kerma values across all hospitals in the state was about 14% of procedures were missing air Kerma values being reported. And so this is something I think that worthy of more discussion at the end of the talk on how we might be able to improve this across the collaborative. So this is what we saw. So you see the pie chart on the left shows the frequency of air Kerma radiation doses of greater than equal to 5 gray across 36,000 PCIs performed in Michigan during the study time period. And that accounted for about 4% of procedures. So you can see about just under a third of procedures had doses between 2 and less than 5 gray. And then the majority of procedures, about 2/3, had doses that were less than 2 gray. And so one of the things that we looked at was 4% of total PCIs, how many patients were actually impacted in the state of Michigan at that time by these high doses? And the answer was about 1,400 patients had a dose in that time period over about a year and a half of an air Kerma of greater than equal to 5. I was actually, and the other investigators were also equally shocked by the number of cases in the state of Michigan that had radiation doses of more than 10 gray and more than 15 gray. And so again, considering that, the Joint Commission might consider a dose of air Kerma of greater than 15 a sentinel event, that happened to more than 100 patients in the state of Michigan over that time frame. And I think this really represents an area of opportunity for us to improve, PCI safety in the state of Michigan by really eliminating the number of patients that are receiving these very high radiation doses. I think that is something worthy for us all to strive for, and maybe something that we could do that would make PCI much safer in the state by having the number of patients with air Kermas of greater than equal to 15 actually 0. And I think that is an achievable goal. So these are the data across the different hospitals and cath labs in the state of Michigan. So this is frequency of PCI cases with a procedural air Kerma of greater than equal to 5. And so each of these bars represents a different hospital, and the frequency is on the y-axis here. And so you can see the frequency ranged from no cases on the left, with an air Kerma of greater than equal to 5, to some hospitals on the right with more than 10% of their total PCI cases actually having these high radiation doses of greater than equal to 5 gray. And so this, again, I think represents an area for opportunity for us to try to improve this, again, to improve safety of PCI in the state of Michigan, because there's greater than a 10-fold difference in the likelihood of having a radiation dose of more than 5 gray, across cath labs in the state of Michigan. So this is definitely something I think that we should try to strive to improve. So we also looked at, asked the question, if hospitals are having high doses of a high percentage of their cases with doses of greater than 5 gray, are those same hospitals also having higher doses in all of their other procedures? And the data shown here suggests, yes, that is the case. So the yellow and red, let me back up. The yellow portion of each of these bars represents doses between 5 and 10 gray. And then the red portion of each of the bars represents the frequency of doses of more than 10 gray. So the previous slide would have shown the data for yellow and red combined, but what the purple bars are here for doses between 2 and 5 gray. And you can see that as the yellow and red, the size of the yellow and red bars more or less increases going from left to right across the graph, you can see that the purple bars also increase left to right across the graph, suggesting that for hospitals that have very high frequencies of doses exceeding 5 gray, those hospitals are also having higher frequency of doses between 2 and 5 gray, suggesting that their cases overall are having much higher radiation doses than others in the collaborative. So again, opportunity for improvement. And so the statisticians with BMC Squared then did some very fancy statistics, which I actually have trouble wrapping my brain around. But in order to determine if a hospital at which a PCI procedure was performed was an independent predictor of a dose of greater than or equal to 5 gray, the performing hospital was included as a random effect in a hierarchical model with patients nested within each model. Again, some fancy statistical mumbo jumbo. But basically what this did is it spit out a median odds ratio, which is an estimate of the contribution of inter-hospital variability in determining the odds of having a procedural error curve of greater than 5 gray during PCI. And what they found was that median odds ratio was roughly 3. And so that means that any given hospital in the state of Michigan has a 3-fold increased risk or odds of having a higher dose than other hospitals in the system. And so this suggested that yes, the hospital at which a PCI is performed is an important contributor to the frequency of a dose of greater than 5 gray. And so, as I said earlier in the talk, the ideal state would be that any hospital that you present at in the state, your risk or your radiation dose that you get would be the same for any given PCI procedure, but that's just not the case currently in the state of Michigan. There are hospitals that have significantly higher radiation doses than others, although the procedure is exactly the same. And so, looking at this a different way, each of the hospitals here represents one of the red bars. And so if you take a patient and that patient has, let's say, a mid-LAD lesion, just as an example, and they went to any number of these hospitals shown in red, that their risk of actually, despite that being a mid-LAD lesion, they would actually have a higher likelihood of getting a dose of more than 5 gray than if they had that same PCI procedure done at one of these 5 hospitals at the bottom, where the dose would be significantly lower. And so again, this is just more data showing that the hospital at which your PCI is performed is a significant determinant of what radiation dose you get. And that is something hopefully that we can improve upon over time. So looking back at these, this figure here, not only do these higher doses for the institutions on the right of this graph impact, patient radiation doses, but I think it's important to remember that all of the radiation that we as physicians receive through the course of our careers, as well as our cath lab staff members, nurses, and circulating our techs, all of the radiation that we get as occupational radiation doses comes from scattered radiation from the patient. And so I would argue that for those hospitals with these very high doses, radiation doses for patients on the right side of this figure, not only are those patients getting higher doses, but it's very likely that because those doses result in more scattered radiation during those procedures, that physicians and staff members who work in those cath labs probably are also receiving higher radiation doses, and that may have significant impacts on their health and well-being. And so this is a slide just showing some of the research that has been done looking at possible radiation-related complications in interventional cardiologists. And so there have been papers showing that interventional cardiologists compared to their non-interventional colleagues are at significantly higher risk for premature cataract formation as a result of occupational radiation exposure. We are at higher risk of developing carotid atherosclerosis, particularly in the left carotid, because that's the side that is closest to the radiation source. And then also possibly an increased risk of left-sided brain malignancy. So again, where we stand in the cath lab in most of our procedures, the left side of our body is closest to the radiation source and to the scattered radiation coming off of the patient. And so our left side of our head receives significantly higher amounts of radiation over the course of our careers than the right sides of our heads. And when registries have looked at interventional cardiologists that have developed brain malignancies, whereas the general population, there's an even 50-50 split between the right and left sides of the brain and where the cancer occurs, in interventional cardiologists, 85% of brain malignancies tend to occur on the left side rather than the right, again, suggesting that there may be an increased risk of left-sided brain cancer amongst interventional cardiologists related to our occupational dose. And so again, it's important for us to be developing ways to make cath lab radiation safety practices better as we march through time. So another very interesting study looking at the risk of radiation during fluoroscopic procedures to physicians was this study done by El Sayed, published in Circulation in 2017. And so you can do a blood draw and actually measure radiation or DNA damage biomarkers, which occur in the setting of radiation-induced damage to DNA. And what these investigators did was they took vascular surgeons who were doing open AAA repair, where they were, incising into physicians or patients' abdomens and replacing or repairing an aortic aneurysm, which those open procedures don't require any radiation. And they compared those to vascular surgeons who were doing fluoroscopically guided endovascular AAA repair, which is basically putting a large stent graft into the aorta, and that is done with fluoroscopy. And what they did for all of those procedures, whether they were the older way of doing it, which is an open repair, versus the newer way, which is endoscopic and using fluoroscopy to do, they drew blood on those physicians immediately before the procedure, immediately after the procedure, and then 24 hours later to see if that after even a single procedure, they could detect evidence of DNA damage thought to be related to the radiation exposure received during the procedure. And for vascular surgeons that were doing open AAA repairs, kind of the old-fashioned way, they did not see any rise and fall in these DNA damage biomarkers. However, for physicians that were doing endovascular AAA repair, where they were using fluoroscopy to accomplish that procedure, they were able to measure after a single procedure a rise and fall in these DNA damage biomarkers, suggesting that radiation dose that the physician received from a single procedure was enough to actually measure damage in DNA. And interestingly, the doses, radiation doses that were used in those cases are very similar to radiation doses that we conventionally get with PCI procedures in the cath lab working on people's hearts. And so again, very provocative research suggesting that maybe even a single procedure and the radiation could have ill outcomes. So, and I think this is getting towards the end here. The one other thing I think that is making this, even more important now, perhaps than ever in the past, is that we are in the midst of an obesity epidemic, where, patient obesity has become more and more common across our society, and we're seeing this more and more often in the cath lab. And the reason that's important is that for patients who have a larger BMI, it takes more radiation in those patients to actually accomplish the procedure and see what we're doing. And so you can see we measured this, the dose area product on the y-axis on the graph in the left, and patient BMI on the x-axis. And in the green bars, you can see that as the patient size goes up, the radiation dose goes up also. And this is, of course, concerning because as patients have gotten larger over time, we are needing to use more radiation, so higher radiation doses for those patients. The question that we asked in this study was, what impact is that having on physicians? And we were actually able to show the same thing, that as the patient BMI goes up, that the physician radiation dose also goes up. And so again, this is just suggesting that, in the obesity epidemic, as patients have gotten larger and radiation doses have become higher, not only does this have implications on the radiation doses that patients are getting, but also the doses that physicians are getting. And we've also replicated this data showing that this also impacts the dose that techs get in the cath lab as well as our nurses. And so this has impacts on the entire cath lab team. And so with patients getting large over time, again, we need better radiation safety practices now more than ever. So just in summary, we have observed across the BMC registry a wide variability in the institutional frequency of procedural doses of more than 5 gray. Even after accounting for patient characteristics and procedural variables, the institution at which any given PCI is performed is found to be a major factor in determining the patient's radiation dose. And this really indicates an opportunity for quality improvement in radiation safety practices across institutions. And then I wanted to end just with a couple of questions that I hope will prompt some discussion. How do we increase the reporting of air karma values after PCI in cath labs in the state of Michigan? As I said earlier, the rate of missing air karma values ranged across hospitals from 3% to 80% of procedures, with the average being about 14% of missing values at any given institution. How do we improve this? And there were, again, 5 centers that didn't report any error karma values. So this is something I think to, again, improve the quality of our data and allow us to do even better studies. Getting better reporting this, I think, would really be impactful. And then what is the impact of fluoroscopy equipment? We suspect that one of the main determinants of these this large variability seen across institutions across the state may have to do with the age of the fluoroscopy equipment. So the fluoro equipment has gotten better and better over time. Newer state-of-the-art fluoroscopy equipment, emits extremely low doses of radiation compared to the older equipment. And I think some of the cath labs on the right side of that figure with more than 10% of their PCIs, having doses exceeding 5 gray really may have to do with the fact that they may be using older equipment. And so this is something that we are interested in studying and are collecting data on this now. What other steps can we take to lower the rate of these high radiation doses across the state? And then, can we develop a systematic approach to addressing patients that have an error karma of greater than 5 gray? And I will state that we recently wrote a radiation safety best practices protocol, which is in its final round of revisions now. And so that's something that is going to be distributed later this year. And hopefully that also will impact favorably radiation safety in our cath labs in Michigan. Thank you.
Thank you, Dr. Matter. That was very informative, semi-scary for people that aren't familiar with what radiation can do for to the staff and for patients. And I know a lot of our sites are working to improve the collection, as you referred to, getting the doses so if you have a problem, and also working on lowering their doses. Are there any questions for Dr. Matter from the coordinators or other people attending the call?
Yes, this is Kelly from Munson. May I ask a question?
Of course, go ahead, Kelly.
So I understand the error karma is in regard to the radiation given to the skin between the heart and the skin. Is that true, or does the error karma take into account the radiation dose going directly to the heart? Because I know in MROC, I worked in MROC for a bit, they've done a whole study on this, and they've determined that the max dose to the heart is 2 gray. And so when they do radiation therapy to the breast or the lung, they're very careful in their dosing in that regard.
Yeah, good question, Kelly. So the error karma is the dose that is actually measured in air at the interventional reference point. It is not the dose that reaches the heart. And so that's an important differentiator. An error karma of 5 gray, that's measured in air at the reference point is the dose that would actually reach the heart would be nowhere near that.
Okay. Thank you.
Thanks, Kelly. Are there any other questions? Oh, I see some in chat. There we go. Oh, thank you for the presentation and improving safety equipment for staff and patients. Yeah, so the best practice protocol will help you with that. I have a couple. So the techniques, and so when we asked sites to present on this, they're like, well, when we noted sites that really improved their number of cases of over 5 grays, we contacted them and they're like, I can't present. All we did was go and adjust the settings in our lab. That's a short presentation, but those things are important. Or when we reached out to coordinators that when we do site visits, we talk about how do you go about collecting your doses. Some places had their cath lab manufacturers come and in-service the staff and show them how to move over those doses and get them on the record. There's been a big variety of what sites have done, but it is simple systematic approaches that you just have to identify the issue and see where your gaps are. But as far as questions, I don't see anybody else, so I'm going to ask, how long in between procedures? So we know with contrast, the doctors want so many days for it to clear out of the kidneys if they're staging a procedure. So patient gets a lot of contrast or their kidneys are not functioning well, so they don't want to load the patient. They'll bring them back usually in a week is what I see. What about radiation? How long is it? So you stop the procedure because of excessive radiation. When is it safe to bring the patient back to finish maybe another artery or whatever they need done?
Yeah, I don't think that we know that. I'm not sure that's been adequately studied. I think that if you have a high dose, I think that's when you really need to get your radiation physicist involved. And I think as a team, including maybe with the help of risk management, discuss when it's going to be safe to bring that patient back. And so unless there's some urgent need to do so, I think at a minimum I would wait 30 days to ensure that there's not any evidence of skin injury. And if at 30 days the skin looks fine, then it's probably okay to bring that patient back. But again, you would want, when that patient comes back, to to make sure that you do everything you can to limit the radiation dose so that they don't get another high dose.
Okay. And it seems, again, this is anecdotal, I don't have data in front of me, that we're getting more female patients. And I know with stress tests, breasts really affect how you can visualize female organs. Is that an issue for large breasted women in the cath lab? I know we can't tell with what we collect in the registry, but is that an issue, or radiation passes through breast tissue much more easily than it does like muscle or?
Yeah, it's a great question, and actually that's something that we're studying at Spectrum right now with our internal radiation data that we've collected. We've shown this relationship between patient BMI and radiation dose, such that as the BMI goes up, the body mass index goes up, the radiation dose goes up also. What we don't know is how sex impacts that, and so. I don't think it'll come as a surprise to anybody on the call that men and women carry their body weight differently in different locations. Tissue density is different in men and women. And so we think that probably all of those factors impact radiation dose. And it's something that we'd like to understand better, that for any given BMI, is the dose lower in a woman than it is a man, or vice versa, because of where the tissue is located, because of breast tissue, because of tissue density. How do all of those things impact the radiation doses to not just patients, but also to those working in the cath lab? And so we're investigating that.
Thank you. I know that your site is on the forefront, largely in part of you. I guess I should just come out and say, but I know that if anybody had the answer, that it would be you. We do have a question from Tracy Hack at the DMC. Are there best practice interventions that we can share with our cath lab? Now, I know they've been authored, and I know Anne Marie's on the call. When would we be posting those, Anne Marie? I'm sorry to throw you under the bus.
We are just kind of finishing up some final edits, and need to do a little polishing, but I would say we'll likely have that posted within the next 3 to 4 weeks would be our goal.
Right,
and I'll add to that. I think at this point, Anne Marie is simply waiting for me to finish the edits.
I wasn't going to say it. I wasn't going to say it. We know how busy you are, and so I should have the draft. I don't think it's going to change a whole lot. There were just a few minor comments that we received from some of our other collaborative members. So hopefully very soon we'll have that up. We are launching our new website at the end of the month. It probably makes the most sense for us to just put it there where it'll be really nice and accessible for everybody. So I imagine you'll see it, by sometime early May.
Yeah,
but
and
like
we actually
the version you have, the draft that we shared around last month, is a good working version if you want to take a look at that now.
Yeah, and I will put a plug in for the best practice protocol. We wrote it in a way to try to make it practical for all team members in the cath lab. And so there is a section on kind of best practices to reduce patient radiation doses. There's a section that physicians can use to, kind of tips and tricks to reduce their own radiation doses in the cath lab. And then we also put a section in directly addressing risks and things that staff members in the cath lab can do. So nurses and techs, tips and tricks that they can do to reduce their doses. And so I'm hopeful that protocol is going to be helpful to all members of the cath lab team, because I don't think that we should just be focusing radiation safety on patients and physicians. It really has to be the entire team, including our nurses and techs in the cath lab.
Thank you, Dr. Matter. I get asked a lot for best practice protocols, and the sites utilize them. So it is time well spent. And this one in particular, I do feel will be utilized. I get asked a lot about where is it. So that's why I wanted to ask for specifics. Are there any other questions? I don't see anything in the chat. All right. So, well, thank you very much, Dr. Matter. That was very interesting and a lot of practical information and a lot of rationale of why we're doing what we're doing. And I think it would be good for the registry to touch base to see the number of sites that still aren't reporting. Again, we're moving through the sites one by one with site visits and working through a lot of those issues. So I'm hoping we'll see improvement next time we take a peek at the data. And there's another
Great.
Thank you from Jamie Shane. So thank you very much for your time and for the awesome presentation.
Great, thank you for having me. And I just want to say to all the coordinators, thank you for all of your hard work. And I think the work you guys do really does improve, safety of PCI in the state of Michigan. So keep up the good work.
Thanks.
Yeah, take care, guys. Bye-bye.